I'm going to go ahead and get started. I want to welcome everybody to today's Aging Initiative webinar. The Aging Initiative is a NIA-funded research infrastructure program that supports research and career development around multiple chronic conditions. That's led by Dr. Jerry Gurewitz. As part of the Aging Initiative, there are several webinars, and in today's webinar series, I'm going to be talking about the 5Ts framework to support the inclusion of older adults across the lifespan. Really with trying to focus this talk today on those with multiple chronic conditions. My name is Barrett Bowling. I'm a geriatrician and a clinical researcher at the Durham VA and Duke, and developed the 5Ts framework as a strategy to help support inclusion of older adults in research studies. I have no conflicts of interest to disclose. Support for the 5Ts comes from the Claude D. Older Americans Independent Center, that's part of the Duke Aging Center, as well as the Integrating Special Population Score through the Duke Clinical and Translational Science Institute. I want to say special thanks to the Tidewell Emerging Leaders in Aging program, the Aging Initiative, and the American Geriatric Society Aging Learning Collaborative, as well as Jennifer Thomas, Ted Johnson, Heather Whitson, and Design Hammer for their support with this program. By the end of today's session, you'll be able to recognize some challenges to inclusion of older adults in research, really with a focus on those who have multiple chronic conditions. And you'll also be able to identify ways that the 5Ts could be used to improve inclusion of this population and how to access 5Ts resources. I'm going to start with a case. This was a new exercise and weight loss clinical trial. And right before the study team went into the field to implement their intervention, they had some community engagement sessions where they tried to learn from potential community members about their study protocol. In one of their listening sessions, some questions came up about why the study was planning to exclude people 65 years and older, and it was actually raised by one of the attendees who asked, "Why can't I be part of this study?" The study team members disagreed on the use of age cutoffs for their study, but really they were worried about meeting their enrollment targets. They were worried that older adults may be at higher risk for adverse events, and they were worried about older adults' ability to participate in an intervention that included the use of technology. So this study team reaches out to you for your help. How are ways that you might be able to help them? So some questions I want you to kind of think about as we walk through this. What implications does a study like this have for persons with multiple chronic conditions? Is a study like this even relevant to those people, or relevant to older adults in general? Should they be included? A next question is around what are some practical advice or practical tips we could give the team to help them think through this inclusion of older adults and how they might address the potential challenges? How could we tailor some recommendations to the specific study needs of this research study? And if those things are helpful, how could we expand this to other research studies? So I want to talk a little bit about the problem of underrepresentation of older adults in research. We know that the prevalence of most chronic conditions increases at older age. However, older adults are often not included in research studies, and this may be through intentional age cutoffs or unintentional exclusion criteria that affect older adults. And really what this means is that results of most research studies, or many research studies, may not be relevant to the patients who need it the most. And we think a lot about this in geriatrics, and when we take care of patients, there's a lot of uncertainty around how we apply evidence to older populations. But this message is also getting outside of geriatrics and aging research. These are two New York Times headlines. The clinical trial is open, the elderly need not apply, and older adults may be left out of some COVID-19 trials. I want to go through a couple of examples. This first example comes from ischemic heart disease drug trials, and it's been shown that 50% of drug trials in this chronic condition have an upper age limit, and that's shown in this figure here to the right, where we see the percent of trials with an upper age cutoff and the year that those studies were registered. This was between 2006 and 2015, and you can see, if anything, the percentage of studies with an upper age cutoff increased during this time period. This is a problem because we know that 40% of patients who are hospitalized with a myocardial infarction are 75 years and older, but they make up only 12% of trial population. So an example of how underrepresentation in an important area, chronic disease area. In addition to age cutoff, there are other ways that older adults can be excluded from research studies. And so this is an example in type 2 diabetes. We know that 77% of diabetes trials have exclusions for comorbidity. That's shown in this figure here. Because multimorbidity is disproportionately common at older ages, just having a comorbidity exclusion unintentionally excludes older adults from research studies. And in addition, this study that looked more into this also made the point that oftentimes research studies don't even justify why they're excluding participants for comorbidities. The age cutoffs aren't allowed by the NIH, and we know this as part of the inclusion across the lifespan policy. This policy states that all ages, including children and older adults, must be included in human subjects research that's conducted or supported by the NIH, unless there are scientific or ethical reasons not to include them. An additional requirement of the inclusion across the lifespan policy is that research studies have to provide data to NIH on age and enrollment. And so we're going to look through some results of that. Shown here are the percentage of people 65 years and older who are part of NIH-funded research studies in 2021. And so what we're seeing here is that clinical research studies and clinical trials, a subset of those in clinical trials, included 19% and 18% people 65 and older. And the way we calculate these are the total number of participants who are 65 years and older divided by the total number of participants. And just to give you some context, there's about 1 million people enrolled in NIH-funded research studies in 2021. If you zoom in to the clinical trials, you see that those who are 75 years old, and when you break it up into smaller age groups, made up less than 5% of all clinical trials among those who were enrolled in 2021. So a big drop off when we look at the older age groups. Added here are some common chronic disease or research category areas that are common among older adults: cardiovascular disease, cancer, lung disease, and diabetes. And I picked these because they're common in older age, and just to show that there is this kind of variability among participation rates across different research categories, as high as 54% among those with cardiovascular disease. These are studies focused on cardiovascular disease, and 10% among those with diabetes. So this doesn't really tell the full story. Added to this slide is the median point. And so the blue bars are the total participation among the total people enrolled in studies. A median point is calculated like if you lined up all of the studies from those that had the fewest number of older adults to those that had the highest number of older adults and found the midway point. And what you can see is overall, and for most of the condition research areas, the median participation among people 65 and older is much lower. And so an example is cardiovascular disease, where the overall participation was 54%, but the median is 4%. And this really suggests that there may be some studies that enroll a lot of older adults. The average study enrolls 4% or fewer older adults. And this is a real problem because most research studies are focused on different research questions. And so the results that come from those may not be relevant to older adults. So let's talk a little bit about underrepresentation of persons with multiple chronic conditions. There's really not a lot of data out there on representation of multiple chronic conditions in research studies focused on single diseases, but we can just extrapolate the fact that we know that 3 in 4 older adults have multiple chronic conditions. Older adults are oftentimes not included in research studies, and therefore it's likely that they make up a smaller proportion than what would be expected given the prevalence of multiple chronic conditions. This is a problem because multiple chronic conditions increase the risk of functional decline, long-term care, hospitalizations, and death. And because these outcomes are important, it would be important to include these patients in research studies. But the typical clinical trial really focuses on a single disease. And I think one way that might be helpful to think through this is to think about a multimorbidity conceptual model. And so while the typical trial is thinking about one condition at a time, if we thought about a multimorbidity conceptual model and tried to apply that, that could be helpful kind of for thinking through what are then the problems of that kind of typical one disease at a time approach. And so this multimorbidity model thinks about, on the left side, some determinants of multimorbidity, and then there being some prevention strategies to try to avoid those. In the middle is thinking about complex patients who have multiple chronic conditions, and some of those conditions may be interacting with each other, or they may be interacting with medications that a patient is taking. And then on the right side, there are outcomes that are important. And between that, there are strategies potentially to treat them, either treat the conditions or kind of model or organize care around treating patients with multimorbidity. And so if you walk through this conceptual model, you can think through, well, what are the problems of a typical clinical trial, and that focuses on a single disease. And so on this kind of prevention side of the conceptual model, a real problem is that oftentimes clinical trials focus on incident disease, and they may exclude those who've already developed more than one chronic condition. And so the consequence is that we have limited evidence on how we can slow the progression of multimorbidity. If you kind of move on to think about the middle part of this conceptual model, and that oftentimes older adults are excluded with any comorbidities, and often that likely impacts those who have discordant chronic conditions or conditions that may make treatment of the main condition more complicated. And so a real consequence is that clinical trials are oftentimes do not generalize to older adults who have multiple chronic conditions or these discordant conditions, which can be a real common and challenging area in clinical practice. And last part of the conceptual model, also kind of thinking about what outcomes are measured. And there's a real problem that that clinical trials focus on disease-specific, or in some cases even intermediate outcomes. And so a consequence is that there's limited evidence to help really guide the discussions around trade-offs, which are really important among those with older adults. Is does treatment of this condition make this other condition worse? Really hard to make those types of decisions if in each of those clinical trials is really focused on one disease-focused outcome. So some examples of the way our kind of typical approach and the underrepresentation of older adults in general may impact our understanding of multimorbidity kind of across this trajectory or conceptual model from development to treatment. So going back to the case, I think that you can make a strong argument that this clinical trial is relevant to older adults and those with multiple chronic conditions. The clinical trial is focusing on obesity and exercise for weight loss, and these are both shared risk factors for many chronic conditions. So thinking about kind of that far left-hand side of the conceptual model, where this type of intervention may be really important for preventing progression of multimorbidity. This intervention may have the potential to improve a whole range of outcomes. And you think about things like pain and function, really kind of thinking about that far right side of the conceptual model. So I think there's a clear argument to be made that this type of research study could be relevant to older adults with multiple chronic conditions. And if that's the case, let's think a little bit more about what are some of the barriers that we might need to address to overcome the challenges that they may face in including older adults. So this is what we've spent a lot of time doing and trying to think about not just age cutoffs that are not allowed in the NIH inclusion across the lifespan policy, but thinking about kind of more practically, what are some common barriers that research teams face when they're trying to enroll or recruit older adults to be part of research studies. To kind of do this, we've listened to over 100 older adults, researchers, and research staff, and we've elicited what are the common challenges that they face or the things that they worry about enrolling older adults in research studies. We took a list of these problems and challenges back to some aging research experts, and we said, well, how would you respond to this challenge? We hear these issues about transportation coming up, or we hear issues around hearing loss. How have you handled these types of problems in your own work? And really elicit a long list of potential recommendations to overcome those challenges. We also review literature to help identify any additional strategies that might exist, really with the idea of coming up with a comprehensive list of potential recommendations that research teams could do to make their work more inclusive of older adults. With all of those recommendations in mind, we developed a framework to try to organize those or make it a little bit easier to remember those recommendations. And so that's what I'll talk about on the next several slides. In talking to investigators who were outside of geriatrics and aging research, but doing research that was relevant to older adults, so cardiovascular disease, cancer, diabetes types trials, we heard things like, we're not sensitive to the issues of aging, or being in a clinical trial is a big commitment, really implying that older adults may not be up to that commitment. We could make special allowances if older age is really important. Otherwise, just don't include them. And we also heard from one person that even asked, is there a framework that could help us think about including older adults in research? And so the main findings from this work really were that there was a lack of knowledge about age-related issues, that research teams oftentimes prioritize making enrollment targets, and older adults can be seen as an impediment to meeting those enrollment targets. And lastly, that research oftentimes focuses on one disease at a time, and so it wasn't always clear why including older adults was even worthwhile. We talked to older adults, and when they thought about participating in research, they thought about it in very personal terms. We heard questions like, why me? Why have you contacted me to be part of this research study? How will my participation help my community or people that I care about? How does what you're asking me to do in this research study fit into all the other things that I have going on into my life? And what do you know about me as a person? So these are kind of personal terms that they thought about participation. And while I think research teams oftentimes think about this balance between risk versus benefit as part of informed consent, older adults oftentimes thought about it along the lines of motivation versus inconvenience. And oftentimes they were motivated by very personal reasons, and they saw inconveniences based on their personal context. And so in situations where motivation was really high, they'd be likely to overcome inconveniences. But when motivation is low, even the most minor inconveniences seem like too much to deal with. There were many inconveniences as well that were compounded at older ages, and we can kind of talk a little bit about that as we go forward. We also talked to research staff, and I think this is the group that's probably maybe the most important and oftentimes under-considered or engaged in this type of work. They play such a pivotal role in working with research participants, operationalizing study protocols, and kind of actually putting those into practice. What we heard from them when they talked about older adults was that oftentimes they've learned by trial and error. So in one study, this worked, and things didn't start out well, but we kind of made this change, and now things kind of worked a little bit better. But when they've learned through this experience, there are rarely opportunities to share this from one study to another. And in fact, even when they go on to another study, there's this kind of feeling that they're having to reinvent the wheel with every new study. There were some challenges that they faced related to older adults in recruitment and retaining them in studies that were really common. And so things like transportation came up a lot. But then there are also some challenges that were really specific to a certain study. And so an example is a study that had to have a blood draw that was timed perfectly with a imaging study. And if someone had a challenge drawing blood from an older patient or participant, that might kind of make it difficult to complete the other steps in their protocol. And so they thought about these study-specific challenges as ones that they might need some extra help with. That sort of a checklist necessarily wouldn't be something that would be kind of as helpful, because it was really specific to the protocol that they were working on. There were some challenges that were really easy, and so just kind of knowing about it and thinking about it ahead of time, it was easy to kind of address. There were others that were ongoing throughout the time of a study, and they may need someone to kind of reach out to as the study's going on for help. Overall, they were very positive about including older adults and enthusiastic about the idea of a framework. But really what we heard from them was that we'd have to be able to tailor that delivery of a framework to specific studies. And they didn't want to hear about recommendations that really weren't relevant to the study that they were working on at that time. So with all of these things in mind, we developed the 5 T's. And I'm going to kind of walk through those in the next several slides. The 5 T's are the target population, team, time, tips to accommodate, and tools. We define the target population as the person, groups, or communities who could benefit from the research. Really thinking about, when all is said and done, who should the findings of this research study generalize to? And then what I'm going to do is I kind of walk through and define each of these T's. I'm going to kind of suggest some resources that we have and recommendations to think about kind of what we mean when we talk about each of these T's. And so if you navigate to our website, the 5Ts framework.duke.edu, if you hover over our 5 T's wheel, hovering over each of the T's, you can learn more about what we mean when we say target population. And then if you click on the T, you can kind of go to see our recommendations list. And so the recommendations are actually 49 best practice recommendations that we came up with to support really from hearing from research teams and what they're doing and what works. And then we kind of went through a process of reviewing the literature to find additional recommendations, and then really trying to kind of distill these kind of hundreds of recommendations down to 49. We describe these as kind of helpful descriptions with examples, quotes. We provide links or even references that can point people to resources to address each of these recommendations. So let's kind of walk through target population as an example. On our website, we had 4 primary recommendations in target population: avoiding exclusion criteria that disproportionately affect older adults, knowing about the demographics and prevalence of age-related limitations and co-occurring chronic conditions among older adults with a condition being studied, knowing about the range and preferences for languages within the target population, and understanding common motivations for participating in research, as well as concerns about participating. Kind of walking through the 5 T's, the next T is team, which includes the researchers, the study staff, as well as participants, families, communities, and healthcare partners. And this very broad definition of team comes from what we heard from research from older adults, that oftentimes they think about their team, including their family members and caregivers, and who else they look to for advice about participating in research. Clicking on the team, you can go to the recommendations. And so here's an example of a recommendation: train team members to recognize and accommodate age-related sensory, functional, and cognitive limitations, really kind of emphasizing the fact that most study staff have learned through trial and error and haven't had training. We provide useful links about some ways that you might do training like this, and also a reference, which is a really interesting paper that has used some simulation type training activities to help teach research teams about how to anticipate and address challenges that older research study participants might face. I also want to point out that in any of these recommendations, if there are some that are particularly helpful, you can print these, save it as a PDF, and share it with your research team. So moving across the wheel to time, we know that inclusion of older adults in research often requires more time. And when we think about time, we think about needing to be flexible with time, about setting the right pace. So this is thinking about the time of a protocol, or what are the procedures that are happening during a study. And we think about how we can limit time requirements. And so this really gets to the idea of inconvenience and burden of participation. Thinking back to what we heard from older adults about their inability to overcome some inconveniences, especially when motivations are low. And so an example here, we recommend that allocate study time to provide updates, to reschedule missed visits, obtain missing study measures or devices, and connect with participants. And this kind of falls under the category of being flexible with time. And this was a quote from a principal investigator who's used these types of approaches, who said that our older participants are more likely to miss visits due to acute illness or dependence on less than reliable transportation, and that this often can cause scheduling problems. But I really like the last sentence there: this investment is worth it, but study teams should anticipate the challenge and budget for the extra effort. Tips to accommodate are some practical strategies and tips that research teams have been using to address age-related barriers to participation. And when you look at the recommendations on our website, you can actually filter through to identify some that may be most applicable to your research study. And so in addition to filtering based on the 5T, and so here we're filtering on tips to accommodate, you can filter based on the data collection method, the study design, the study setting, as well as the activity, and who you're most interested in, the person or the group that you're most interested in. So here shows just some examples of tips to accommodate filtered for the protocol development and thinking about allowing participants to complete some or all of the data collection from home, and that might be through telephone or web-based, and asking about and observing for signs of hearing difficulty. So just two examples of where some of these recommendations come in when you're thinking about the protocol development. Again, this is where we have recommendations around transportation and those kind of common challenges that arise related to age-related sensory, functional, cognitive challenges to participating in a research study. And then tools include instrument aids, materials that might be helpful for actually implementing the research study, but also ways to measure outcomes that matter most to older adults. And so what we heard from older adults is that oftentimes they're motivated to participate in studies that are measuring or trying to impact things that are important to them. And so having tools to measure what matter most could be a strategy to increase motivation for participation. And so some examples of the types of tools and recommendations that we have under tools are selecting appropriate tools to measure outcomes that are important to older adults. And so we have some great examples of those, and I highlight one that comes from the collaboration between the Pepper Center and the Aging Initiative, which is called the Geriatric Research Instrument Library, or GRIL, and that could be a helpful set of tools to measure things like cognition or depression or function. So to go back to the case and kind of think a little bit about how we might tailor recommendations to some specific study needs. And really this comes from what we heard from research teams, that a one-size-fits-all approach doesn't work, and that really resonates for us in geriatrics. What we heard from research teams is that oftentimes they have very different study designs, where they're doing the study, the team members that they have, the budgets that they have can be really different. So you can imagine the ability to include older adults in a small pilot study or to budget for additional time may be very different than in a study that has a much larger budget. And so research teams wanted recommendations, but they also wanted to think about, well, what recommendations are most relevant to their study. And the way we've operationalized this is by having research teams kind of go through a few steps. And the first step is to try to think about and answer some key questions really relevant to each T. So having the 5 Ts be a starting point or a structure to answer some important questions. And then with those questions answered, to think about, okay, well, what would be a plan to address them? What recommendations that are available are most applicable to the challenge that we face? And so we have a resource on the website that we found is helpful for research teams in structuring these conversations. It's under the resource tab, and we've called it the 5 Ts Inclusion Worksheet. And it looks something like this. And the idea is that really this worksheet or this structure is a way to kind of walk through each T with a research team, help them think about their study, and then what they would do to address the likely challenges that they may face. And so I think this is really, we found this to be a helpful way to do this because research teams know their studies the best. And giving them recommendations that either aren't relevant or that they aren't asking for, I think are less likely to be used, and also may be less helpful or relevant to them. So when we think about these questions, these are some examples of the things that we walk through in thinking about the target population. What's the target treatment population? Or who should the results of the study generalize to? When it all is said and done, who is this group that you're really trying to impact? Do they include older adults? If so, are chronic conditions common among those? Kind of starting to think about that target treatment population. We think about the team. What team members will be interacting with older adults? What training do they need? Who else should we include in the team? Thinking about it kind of broadly from the perspective of the patient who's on their team. We think about time. How long will the study visit last for someone who has no physical limitations? Or what if they have functional or sensory limitations? What type of time burden might it be in those populations? Thinking about some tips to accommodate, really we asked research teams to think about the how, the when, where, and what are participants asked to do kind of at each step, and then think about, well, how would having some functional limitations affect their ability to participate in that step? Can we anticipate some of those problems and try to address them before they happen? And then tools, we think about, well, how do we know if we've enrolled the right number of older adults, or what kind of measures could we be including to make sure that we're measuring what matters most? So with this example research study, what we heard was that oftentimes the team members were really worried that frail older adults would not benefit from the intervention. And they were worried that if they had already been losing weight as part of a frailty syndrome, that having them try to lose weight as the intervention would not be something that they would want. They had some unsupervised exercise, and if they were at risk for falling and they were frail, maybe that they would be at risk for having an adverse event. And so oftentimes they had that kind of an image in their heads of an older adult who was frail. And as the research team even kind of started to talk through this, they even recognized the idea, well, that there's really a wide spectrum of function and health among older adults. We really began to kind of question, well, is age kind of what we were worried about, or is there something else? Kind of looking to the target population recommendations, one of our recommendations is to avoid exclusion criteria that disproportionately affect older adults. And if you expand that, really what we're talking about are comorbidities, functional limitations, hearing and vision impairments, cognitive impairment. So I kind of want to kind of make the point that it's not helpful in many situations to use age as a proxy for frailty or for risk for adverse events. And so there's some references here to kind of help think these through. So when the research team saw this, they kind of came back and said, okay, well, that's really not what we're thinking about, that it's kind of older adults aren't likely to benefit from participation, but really that it's an issue that age isn't kind of a proxy for frailty or nutrition risk. And even within that research team, they recognize, well, we kind of have a good sense of what are some measures of risk. Could we use those instead of age? And actually what they kind of did from that step was kind of walk through each of these research, each of these T's, and kind of came up with plans. When they thought about their team, they thought about the nutrition team that was working with participants, the physical therapist who was part of it, each research staff. And so they really identified that there are actually some team members who could help assess nutrition risk and fall risk. They also identified some ways to build in some training for the research staff who had less engagement or less experience working with older adults. When they thought about time, they thought about ways to prepare for additional time. A major component of their intervention was the use of an app that allowed patients and participants to track their participation in exercise and diet interventions. And they could build in more time. When they thought about tips to accommodate, the research team recognized that their app-based monitoring that had these incentives that was tied to it really may be challenging for some older adults. And so they came up with a plan to identify a family member to support their use and measure readiness for using the app. And then for tools, they thought about really a major kind of aid that would be helpful to support meaningful participation. In this case, was some instructions for using the app. And they even came up with the idea of kind of making that easy to read for their older participants. So here's some examples of how a research team used the 5 T's to structure their conversations and discussions and planning about their specific research team, and come up with some examples of and actionable plans for how they might address these challenges. So this was a success case. There was, by the end of their discussions, they got rid of the age cutoff, which probably they shouldn't have had in the first place, but they got rid of that. They decided to incorporate several recommendations that they identified as being most helpful. And so these weren't things that the 5Ts research team told them to do, but they were ones that they felt like would be most helpful. And because of that, they were more likely to implement those. At last time we checked in with the study team, they had enrolled multiple older adults, including one 75-year-old. And so hopefully this is kind of a helpful case to think through, okay, what were the steps that this research team used? And so kind of coming back to this case and thinking about, well, if there are studies out there that are relevant to older adults with multiple chronic conditions, and there are ways that we can provide both some general recommendations and some more tailored recommendations to help overcome challenges to participation, how then could we expand this to other research studies? And so our dissemination approach has really kind of focused on publishing some of the work that we've done, conducting in-person and virtual training, trying to have strategic partnerships, and then providing access to resources and education. And so in our publications, I kind of point out a few publications that we've had related to the 5Ts. Our trainings have really been supported by the Pepper Center, both for research education component scholars at Duke, but also through a CTSI research recruitment certificate. And that's, again, one of these areas where we've been able to interact with research staff or people who are training to become research coordinators who have found the program to be particularly helpful. We're also part of the NIH Summer Institute on Behavioral and Clinical Trials, and this is the first year that we've been able to participate in that. We've had strategic partnerships both kind of locally with our CTSI, Pepper Center, but also with the Aging Initiative, as well as the AGS Aging Learning Collaboratory. And I'll kind of talk about that on the next slide. And then we also have several kind of new partnerships that we've been trying to establish around NIH Pragmatic Trials Collaboratory, as well as with the Durham VA Health Systems Research. And then we provide access to resources both through the 5Ts website, as well as the AGS Aging Learning Collaborative, the Multiple Chronic Conditions Research curriculum. And so here is just one slide as to provide some access to the AGS Aging Learning Collaborative, the 5Ts, and many other strategies to improve inclusion of older adults in research studies are part of this MCC's research curriculum. And so I kind of point you to their website. They also have online community, these sort of self-directed online presentations and teaching slides, podcasts, and recorded webinars. And so those can be accessed here. And really, you know, our ongoing work right now is thinking about how we adapt the 5Ts to new research approaches or other research strategies. We're spending time thinking about how this might be helpful in pragmatic trials, to continue field testing the 5Ts and identify additional tools to facilitate implementation, thinking about ways that we could sustain this and scale this up, and some infrastructure needs that might go into making sure that this is something that could be available to people who need it. So as a summary, exclusion of older adults with multiple chronic conditions really limits our ability to care for a patient population who have the greatest needs. The 5Ts provides a structured approach and some best practices recommendations to support inclusion, and really an overall strategy for then applying that to an individual research study. And that we have additional resources that are probably going to be needed and to adapt and field test and disseminate the 5Ts. So I'm going to end there. Here's the QR code for the 5Ts framework website, and I'm happy to take some questions from the group.
Thank you for that great presentation, Barrett. This is a really wonderful tool for research teams. I encourage everybody to check out the website for the 5T framework that I linked just now in the chat. As Barrett mentioned, we'll now open up for questions. So feel free to put your question either in the chat or raise your hand, and I can turn you off of mute. As we're sort of waiting for questions to come in, Barrett, I'm curious to hear a little bit more about how the 5Ts framework might be especially useful or applicable to junior faculty, including our MCC scholars who are present on the call.
Yeah, I think in thinking about the audience for this work, we had a couple of folks in mind, and one of those are research staff, and then the other really were folks who are newer to aging research. And I think a lot of times when I kind of talk about this and the types of recommendations, it feels a little bit like preaching to the choir when you're giving this work to experienced aging research investigators. But I think that the early career folks are perfect audience for this type of work. I think kind of looking through the recommendations could be helpful for thinking about things that maybe they haven't had an experience with, and to kind of avoid some of this trial and error recruiting approach, which I think is kind of a common theme as people kind of develop experience and build up their research careers. I think the other kind of piece where I've kind of found it most helpful is in collaborating with and interacting with their research teams. And this is kind of a real new skill set when you're early in your research career. Is oftentimes you have kind of a small research team, but it may be your first time working with a research coordinator or a research assistant. And I know, kind of thinking back in my own career, there were times where I felt like, well, the research staff kind of knows a lot more than I do, or maybe there were things that I knew that I wanted to kind of tell them about, but didn't have quite an avenue to kind of do it, or wasn't quite sure how to bring it up without seeming like maybe I was questioning their experience or what they felt like kind of some next steps were. So I think this kind of using this tool in a team setting when you're an early career investigator, doing it not alone, but doing it with your research team can be a helpful kind of team building experience. And then I think it also results in some actionable items that you can implement in your study. And so I think any kind of situation where you have some structure to those meetings can be really helpful. And I think we've kind of seen several examples where this has been a helpful structure.
Yeah, that's great. Just curious to hear about, do you have any more examples that you might want to share of success stories? I know you discussed a few, and perusing the website, there's a bunch of great examples there as well, but just curious to hear.
Yeah. I think that another example, a lot of the work that I do is really in working with folks outside of geriatrics. And so I've had this opportunity to work with cardiologists and with epidemiologists and clinical researchers who really are conducting work that's relevant to older adults, but that's not their focus. And so an example, I worked with Kaiser Permanente of Southern California on a study looking at blood pressure, ways to measure blood pressure, and with a group who were experts in blood pressure measurement. And one of the strategies they use for blood pressure measurement is something called ambulatory blood pressure monitoring. So you wear a blood pressure cuff and it goes off every 20 minutes all day long. And they've done this in studies, hundreds and hundreds of people in their 20s and 30s and 40s who, strap this on and wear it for a day, send it back, and there are no problems. And they were really interested in this idea of, well, could some of the readings that come from a blood pressure measurement like that help think about older adults, treatment of blood pressure in older adults, or even their risk of falling if their blood pressure is dropping during the middle of the night, for an example, but really didn't have any experience working with older adults. And some of the strategies that they have used in younger populations really weren't applicable to this population. And so by working through the 5Ts and thinking about these kind of challenges and how they might want to adapt what kind of successful protocols and I would say middle-aged populations, the 5Ts gave them an opportunity to adapt those to older adults. And that study just wrapped up and enrolled hundreds of older adults who had high blood pressure and who were at risk for falls. And I think it was, again, kind of a lot of feedback from the team that it was so much more helpful to think about that on the front end rather than kind of getting into the study and being like, okay, what's going on? We're not getting all the measurements that we thought we were going to get. The quality of the measurements is not as good. And so that's sort of just another example of a successful use of the 5 Ts.
That's great. Thank you for sharing that. Looks like there's a couple questions in the chat. The first one is coming from Ana Quinones. Ana says, this was a really great presentation, Barrett. Thank you. The 5 Ts are a great process to apply to make sure we are proactively thinking about potential problems and developing workarounds and conducting our trials. What are your thoughts on how to make sure we are transparent on trial details to help others replicate our processes and make findings reproducible? And I'm also happy to unmute Anna to elaborate on that question.
Yeah, it's a good question. And I think it is, we've looked at several kind of trials recently in trying to understand their participation of older adults in those studies, really kind of moving beyond just what was the average age of people in the studies, but was this research study representative of the types of patients that we take care of? And so not just about age, but based on their co-occurrence of chronic conditions, around their functional status, around their kind of risk for adverse events. And I think oftentimes in clinical trials, those types of exclusion criteria show up in supplemental materials. Oftentimes, research teams don't measure things like function to really help us generalize. So I think kind of thinking about a tool as we add tools or measures to ongoing research studies, measuring function, even if it's not the main outcome of a study, is incredibly important for thinking about, well, how does this study population, or how representative of this study population to the patient population? And so those might be some examples of ways that kind of on the back end, I think that each of these Ts could be applied, maybe not so much the tips to accommodate and the time, which we really are about kind of being in the field, helping recruitment, but definitely around target population, the team and tools for really trying to assess, well, how inclusive was this work that was done? It really, so that's kind of, after the study is done, trying to understand. And I think the same issues kind of apply around target population and tools for thinking about, well, was this an inclusive research study? But I'd be happy to talk more about kind of ways maybe that could even be operationalized.
Great. I see another question in the chat from Talika Garg. Talika says, do you have suggestions for including /enrolling /consenting older adults with cognitive impairment into studies that don't focus on dementia?
Yeah, that's a great question. And I think in one of the resources, there was some work that was led by the CTSAs around inclusion across the lifespan. And I think they had a really nice session on that. I would say maybe provide a little bit more specifics than what I can provide right now. I would think about it, but this is this kind of issue, and this is kind of how we talk to research teams and kind of try to come up with these kind of challenging decisions, is really thinking about, okay, well, what is the target population? And do older adults who have dementia or older adults who have cognitive impairment that's not dementia, are they part of the target population for this treatment? And I think the example case of a self-guided weight loss and exercise program, I would argue that maybe persons with dementia aren't part of the target treatment population for that study. On the other hand, there might be studies where the treatment is a medication and they are part of the target population. But I do think kind of really thinking through that, who should these results generalize to, and understanding that target population part, and having that kind of those discussions with your team guide decisions about, well, should we include persons with dementia? And then kind of coming up with a plan for if you decide that that makes the most sense, then how you include them. So it's kind of taking it a few steps back and thinking it through. Oftentimes, there are several examples of research studies where we said, well, we're making some exclusions. We were trying to be inclusive, but we're making these exclusions. And the 5Ts help the team think through what was the scientific rationale for those exclusions. And so you don't want the reason for exclusion to be, well, it would just be easier if we didn't have to bother with people who may be at risk for falling, or it would just be easier if we just knew everybody had good cognition. But that's not a scientific justification or rationale. Thinking about the treatment target population helps you get to a scientific rationale for why you might make these exclusions. And again, I don't think they're necessarily a right or wrong decisions around this, but really it is about how does that fit with what the current study is and what the current study needs.
Great. I see another question from Anna Hung in the chat. And again, feel free, anyone who would like to come off mute, I'm happy to do so. If you just raise your hand, I can click. Anna Hung says, thanks for a great presentation and an impressive website. I like that team and time are called out. Could you talk about any ideas around maybe newer types of dissemination activities that we could consider for older adults and their caregivers? For example, to report study findings back to the research participants and or their communities.
Yeah, those are great points. I think we do have some recommendations specific to that. I guess where I would kind of tie it most is really around this motivation for participation and this kind of balance between having motivation for participation versus reducing the inconveniences. And I think that kind of is the strategy that is most helpful in supporting inclusion of older adults. Around that motivation, though, really is in understanding not just in personal terms, what am I going to get? What might I get out of this study? And I think that reporting back results, we've kind of heard time and again is one of the ways that you can show that both you're measuring what's important and then you're giving it back to the patient and to the study participant as well as their caregivers. So I'd be happy to hear, one of the things about the framework that's so helpful isn't necessarily that I know all of the best recommendations for all of these, but it is a nice way to organize them. So no, and if you have some ideas in mind, please send them my way, or if you want to come off and mute and describe some of that work that you might be doing, it would be really exciting and a way to kind of disseminate kind of what you're coming across and what you've found to be helpful.
Yeah, hello. Are you able to hear me?
Yeah.
Okay, great. Yeah, I think I don't have particular findings, but I'm kind of just thinking about, future grants and, talking about, so I was talking with one of my mentors about this, like how do we feed the information back to the research participants?
Mm-hmm.
And that's why I was curious, if you had found anything through looking through all those articles around that topic. I'd be curious. It's always hard to account for that because usually, there's not much time at the end of the grant and we have very specific items that we're typically targeting. So yeah, I don't have any answers either. Would love to work with you more on that, but
Yeah.
yeah.
That would be something fun to work on. I think the recommendation that I'm thinking most about now, I'm trying to remember if we have it on the website under tools or under tips to accommodate, talked about some of the work that the STRIDE implementation outcome, that was the implementation study around fall prevention and some of the tools that they use to kind of interact with participants and provide feedback. There might be some helpful examples there, but it feels like this is an area that's open for research. And again, I think what we hear is that oftentimes teams they've learned to do this on their own through trial and error.
Yeah.
But there aren't a lot of ways to kind of, all right, let's kind of communicate this from one study to another, or kind of share these resources.
Right. Right.
So let's think more about that.
Yeah, I see one more question in the chat. Donna Lisi says, how would you approach deprescribing studies across the generations where you can get glandular on who benefits most without a focus on deprescribing end of life or healthcare rationing?
Yeah, that sounds like an important area. I might need a little bit more information to give some guidance. I think that maybe it's kind of a question around the target, thinking about the target population. And I do, this is where I think that a lot of EHR work, claims-based work, large kind of cohort studies can be really helpful in trying to describe, on a big picture standpoint, kind of what populations are that we're interested in. Kind of where some of that work, I think, kind of maybe fails is at more of the kind of granular type details that maybe you're thinking about. And that might be where more qualitative work could be helpful for thinking about potential challenges to deprescribing or trying to understand the population at a more granular level. I mean, I think it's always this kind of tension in, I think, aging research and I think also in kind of population health, between kind of these sort of snapshots about a large scale population where you're trying to summarize across many, oftentimes heterogeneous groups of people that are all older, but can be very heterogeneous, to kind of these individual challenges and issues. And I think that, I guess what I would just kind of end on is that oftentimes then the strategies to kind of address those, you might need more than one approach. And so maybe that's helpful. But also I'd be glad to kind of take questions offline if there's something more specific that maybe I could help out with.
Thank you so much, Barrett. That was a wonderful presentation, great resource. Just in the last minute, I'll encourage everyone again to check out the 5Ts framework website linked in the chat, as well as the AGS Aging Learning Collaborative that Barrett called out, also linked in the chat. Those links will be circulated following the call, and in the coming days, a recording of the webinar will be posted to the Aging Initiative website, as well as circulated via email. So thank you again, everybody, for participating. Thanks to Barrett for a great presentation, and wish you all a good rest of your day.